السلام عليكم. مساء الخير عليكم جميعا، كل عام وانتم بخير واواخر علينا وعليكم ان شاء الله، وكل سنه وانتم طيبين. طبعا اليوم تكمله لمبادره وفاء للدكتوره وحمله الدكتوره مها الدباغ بتنسيق من الدكتور عادل الحربي والاستاذ فيصل الله يعطيهم العافيه. كل يوم في اكتيفيتي موجوده على مدى الاسبوع اللي فات والاسبوع هذا ان شاء الله. هذه طبعا مبادرات توعيه طب صدر الاطفال تقيمها مجموعه السعوديه لطب صدر الاطفال. كان في قبلها الملتقى الافتراضي التوعي للتليف الكيس الرئوي بنكرياس. طب welcome everybody. السلام عليكم. Today we will have the childhood asthma in the aura of the COVID-19, and this is مبادرة دكتورة مها الدباغ arranged by the Pediatric Saudi Pulmonology Association. We will have three presentations, short presentations. So each presentation, it will be around 20 to 25 minutes. The first presentation about the guidelines of the childhood asthma, and then Dr. Turki Alahmadi will talk about the link between asthma and the COVID-19, and Dr. Alshamrani will talk about the Pediatric Saudi Pulmonology Association recommendations for asthma and the COVID-19. At the end, we'll have 20 to 25 minutes that you can raise your question by writing it in the box of the Q&A, question and answer. And if you have any other issue, you can also write it down and then we'll take care of. So I will start this session with my presentation to talk about the new recommendation by the GINA group and the Saudi Pediatric also regarding the childhood asthma. So as you know, there was a lot of concern, misuse and abuse of the short-acting beta agonist. Most of the community, they thought, and also they think that this is a rescue medication and they will not use any other medication because they have the rescue medication. So what are the new changes that recently? If you look for the data and the national, international also, concept or understanding of use of medication, if you found that what are the percentage of children with asthma who use the medicine. So 68% they use the rescue medication, whereas 55% they use the controller medication. Either 30% they use on regular basis. If you can see, 70% they will not use, or they use as needed, not as required, or the recommendation of the guidelines. In the Gulf area, we have a different people. So range between Oman, 10% to Saudi Arabia, around 24%. Either increase or decrease in the number that depend. We don't have an accurate data, but we have some researches and questionnaires that's made to estimate how much percentage the prevalence of asthma in children in Saudi. So I'll talk about what are the new guidelines regarding the use of the short-acting beta agonist in mild asthma. So my concern that is I'll talk mainly about in the use of guidelines and the recommendation for those people, they have a mild asthma. I'll talk about the rationales behind, what are the clinical data regarding the acute worsening and exacerbation, and if there is time, I'll talk about the cost effectiveness. So maybe I will answer it later So what are the percentage of mild asthma in children? Is it 25 to 50%? It's less than 30%, 70 to 90%, or 50 to 75%. The second question that, what are the preferred choice of control for step 1 treatment for those children with mild asthma? If I have a child, he's 80 years old, low dose inhaled steroid and long-acting beta agonist, or show as needed low dose inhaled steroid with long-acting beta agonist, low dose inhaled steroid and long-acting beta agonist, or a medium dose steroid, or as needed short-acting beta agonist. What are the new guidelines regarding this? And if I have a child less than 5 years of age, he got an intermittent mild asthma, viral induced with no interval symptoms, with no underlying atopy, and he's using inhaled short-acting beta agonist, but not sufficient, still symptomatic. So what is the available option for control and medication according to the latest GINA guidelines? Can you give him an intermittent high-dose inhaled steroid, low-dose daily inhaled steroid, or medium dose, or as needed short-acting beta agonist? What are the background for the change in 2019? What are the risks of mild asthma? Inhaled short-acting beta agonists have been the first-line treatment for asthmatic children or asthma for 50 years. This dates from an era when the asthma initially thought to be a disease of the bronchoconstriction. Patient satisfaction with reliance on the short-acting beta agonist reinforced by the rapid relief of the symptoms. So most of the patients, they believe in the short-acting beta agonist because when you give them, they have a relief of their symptoms. And also because of the low cost of those medications. Patients commonly believe that my reliever gives me a control over my asthma. So they often don't see the need for additional treatment. And this is actually the real one. But what are the background that if you use the short-acting beta agonist as the only treatment? Based on different studies, the frequent or regular use of short-acting beta agonist showed that beta receptor downregulation decreased in the bronchoprotections. There is also rebound hyperresponsiveness and decrease in the bronchodilator response. That will increase the allergic response, and also it can cause increase in the eosinophilic airway inflammation. And also, if you're abusing or using more than 3 canisters of the inhaled short-acting beta agonist, that increase the risk for the emergency department presentation. So that will increase the morbidity and the mortality of the asthma if you are using only short-acting beta agonist. Also, Kraft showed that episode where they believed using the inhaled beta agonist will increase, and also decrease use of the inhaled steroid will increase the exacerbation rate. What are the recommendations or the new recommendation? So because in children, they are not like an adult. So we have a different age groups where they can use the medication accordingly. If you start with adolescent, that's 12 years of age or older, the treatment with short-acting beta agonist alone is not recommended. As you know, step 1 guidelines before they do recommend to use a short-acting beta agonist. But now they change it for adolescent or children 12 years of age or older. So patients with symptoms less than twice per month, and there's no exacerbation risk factors, that means they have a mild asthma, you start them with a GINA step 1. And the step 1 now, their preferred therapy is a low-dose inhaled steroid with long-acting beta agonist formoterol, taken on as needed basis for symptom relief. Other controlling options, low dose of inhaled steroid can be used wherever you use the short-acting beta agonist. If you look for the left side, here in step 1, the recommendation as needed low dose inhaled steroid with formoterol, or alternatively, you can use a low dose inhaled steroid alone with the short-acting beta agonist. That will control their asthma and also as a measure to prevent the exacerbation. The second age group between our less than 12 years of age to 6 years of age. So in this, we have 2 steps. Patients with symptoms less than twice per month and no exacerbation risk factor, those they have a mild asthma, the recommendation therapy is as needed short-acting beta agonist, the same, but also they advise to use low-dose inhaled steroid. No more single use of the short-acting beta agonist alone. Or if the children, they have mild to moderate asthma, that means symptom twice per month or more with a risk factor for exacerbation. If you want to start step 2, low dose inhaled steroid with a short-acting beta agonist, or you can use other medication. Here, this is the summary for the stepwise therapy in the GINA guideline 2020 and 19. What about the category number 3, or children 5 years of age or younger? What are the modality and the treatment? For those children, actually, who have wheezing episodes, they're not diagnosed yet with asthma, or they have frequent or infrequent wheezers, sometimes we give a trial therapy, especially if there is a risk factor or other association. Sometimes they show the recurrent bronchitis and then show that some improvement with treatment. So should be provided with an inhaled short-acting beta agonist, and that's evidence D. Although it's not effective in all children, but also use of the short-acting beta agonist to relieve their symptoms on average more than twice per week or over a 1-month period indicate need for control medication or a trial of the inhaled low-dose inhaled steroid. If those children, they have an intermittent viral-induced wheeze with no interval symptoms, and those underlying atopy, if there is a history of atopy or underlying atopy, inhaled steroid is not sufficient. That's the answer of the MCQ. So intermittent high-dose inhaled steroid can be considered. But also we have to weigh the risk plus the benefit with the side effect, and also about the concept and the concern of the family. Here is the summary regarding that children younger than 5 years of age. Other modalities like leukotriene's receptor antagonist also can be used, another depend. But the recommendation not only to give the medication, you have to make sure about the exacerbation, you have to look for the side effect of the medication, what are the parent satisfaction, if there is any comorbid disease, what are, if other, like non-compliance, poor using of the medication or the technique. and most commonly in our country, the steroid phobia, or they concern about medication of asthma. So they don't like the steroid. Everybody gets worried about the steroid. Some of the physicians also, they have the same concept. Although we are giving inhaled one or nebulized one accordingly, small doses, sometimes we have the guidelines to follow, but still people, they have a concern regarding use of the inhaled steroid. And as you know, here in the guidelines, people moving to the use of the inhaled steroid in the first line of the treatment. If you look for the beta-2 agonist, what are the groups or different types? We have the short-acting beta agonist commonly used for the rescue medication or in the emergency room or at home. We have a different group. We have the long-acting beta agonist. The most common one is the formoterol, and we have also the salmeterol as a single monotherapy or a combination. And I will just a bit talk about why they do recommend the formoterol, not the salmeterol. And there is also another group is called the ultra-long beta-2 agonist, and this is philanterol, have been used in adults, especially in COPD and some of the cystic fibrosis patients, and showed that good results. So why the recommendation to use inhaled steroid with the formoterol? Why not salmeterol? The reason because although the formoterol is short-acting, long-acting beta agonist, but the onset of action, it takes 2 to 3 minutes, similar to albuterol or the short-acting beta agonist. Where if you can see in salmeterol, the onset of action, it will take 30 minutes. And that's both actually the duration of action is more than 12 hours. And here the philanterol, can be a monotherapy or also combination. Maybe sooner we can use it in children, or the recommendation would change it and approve to be used in children. But in the States, they started already. The short-acting beta agonist alone, such patient, yes, it will relieve their symptoms, but also may contribute to other short-acting beta agonist overuse or misuse. People with mild asthma, the perception of a quick relief evident when the short-acting beta agonists are used, contribute to over-reliance of the short-acting beta agonist compared to a controller where the action of the medication are not immediately perceivable. Overuse of reliever medication associated with a poor asthma outcome, such as exacerbation and even death. So it will increase the morbidity and the mortality. An early study showed that higher use of short-acting beta agonists in the absence of the effective anti-inflammatory treatment was associated with increased risk of asthma exacerbation, hospital admissions, and asthma-related death, as well as amplified level of the airway inflammation. For that reason, the new recommendation by the GINA report highlight significant update in the mild asthma management, and also a clear deviation from the decades of the clinical practice mandating the use of the symptom-driven short-acting beta agonist treatment alone in those mild asthma. And a further study that the patient with asthma, however, showed that protection of beta-2 agonist initially provided to the airway agonist respective stimuli was reduced with time or with a regular use of the short-acting beta agonist, what they call it tachyphylaxis. Other group, the European Respiratory Journal, that's also consensus came with the frequent use of short-acting beta agonists associated with adverse asthma outcome, and evidence suggests that replacing short-acting beta agonist with a fast-acting, long-acting beta agonist inhaled steroid to relieve the therapy, decrease the asthma exacerbation, and also we believe the time has come to move away from short-acting beta agonist in asthma management. We never know. I will end up my presentation with the two studies, big study that's done to show that what are the efficacy and efficiency of those medications, especially the inhaled combined budesonide formoterol compared to the as-needed short-acting beta agonist. One of the studies called Sigma study, where the step 1 for patients with symptoms, they took patients with mild asthma, there is no exacerbation risk factor. They gave them low-dose inhaled steroid formoterol, and the control group giving the short-acting beta agonist. And showed that giving a budesonide or giving that steroid formoterol compared to the short-acting beta agonist showed that reduction in the severe exacerbation. And also was achieved the goals of the asthma treatment between step 1 and step 2. Another studies of big group studies, use of piclomethasone as a rescue treatment for children with a mild resistant asthma, called PIXA study, one of the randomized double-blinded placebo controls, where they gave a 44 weeks 4 treatment trials given as children 5 years or more, wherein they divide them, the first group receiving a 1 puff of the piclomethasone, and then piclomethasone with short-acting beta agonist, short-acting beta agonist and control group. So there is a 4 group actually. And the outcome showed that inhaled steroid versus short-acting beta cannot be assumed to be the same as needed inhaled steroid formoterol. So all the studies showed that there is a benefit of using inhaled steroid with long-acting beta agonist. So in conclusion, to conclude my presentation, recurrent use of the short-acting beta agonist is associated with a beta cell desensitization. Regular use of the short-acting beta agonist increase the hyperresponsiveness in the lung, leading to a great sensitivity to the triggers. I will end up my presentation, and it's a pleasure to introduce Dr. Turki Alahmadi. He's the head of pediatric department at King Abdulaziz University Hospital. He will talk about if there is any link between the asthma and the COVID-19. Dr. Turki, please.
Hey, assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum.
عليكم السلام ورحمة الله. Carry on.
السلايدز واضحة؟
نعم يس.
السلام عليكم ورحمة الله وبركاته، كل عام وانتم بخير، الله يعطيكم الصحة والعافية جميعا ويبعد الشر عنكم ويقينا ويقيكم شر الجائحة وأن يعيدنا بخير وصحة وعافية ونراكم جميعا بخير و فيس تو فيس إن شاء الله عن قريب يا ربي. اللهم صل وسلم عليه. It's a very concise presentation where I'm trying to see if there are any published data about the correlation between COVID-19 and asthma. Is they are higher risk, lower risk? And what do we know so far about the link of COVID to asthma? I always start with this slide in all my presentation when I talk about asthma, and everyone, and I just wanted to look at the red thing. It's a chronic inflammation of the airways. That chronic inflammation, and this cartoon just to say, it's a complex processes that are linked in different ways in different patients, different phenotypes, but the hallmark is inflammation. And that inflammation give you that typical symptoms, airway hyperresponsiveness, the airway obstruction, and they give you the variety of the clinical symptoms we see. That pathophysiology give you that pathology, or give you this pathology, where you can see this mucus plugging, the goblet cell proliferation, the changes that you see, the basement membrane thickening, the smooth muscle proliferation. So the most important question I think that we have to ask is, are asthmatic patients more prone to respiratory infections? If you look at this pathology, and if you look at this slide, you would say it makes sense. Either they are more prone to infections, or infections give you this disease. And this is the diagram. Where's the egg? Which one is the egg and which one is the chicken? Is inflammation give you infection, or infection give you inflammation? Is microbes give you asthma, or asthma put you at a higher risk to have microbes? Let's see this association, and we will navigate this association through other bacteria and viruses other than corona. So let's start with pneumococcal disease. I mean, it's a well-established association of pneumococcal disease, especially serious, or what some people call it invasive pneumococcal disease, with asthma. And you can see in this article where they found, if you have an asthma patient, I mean, no mean that you don't have, and that's the reference, then yes, if you have asthma, you have 1.8 to 2.4 adjusted odds ratio to have serious pulmonary disease or invasive pneumococcal disease if you have asthma. And that risk get a bit more if you are an adult patient. This is another study putting the association of pneumococcal disease with asthma, and you can see in this patient, in this cohort of patient, where they took about 635 patients and they control it with almost 10 times that number. And what they found, if you look here, asthma patient in that cohort were 18%. Whereas only 8% in the control. That gives you an adjusted odds ratio of 2.4. If you have asthma, you have 2.4 times the risk to have invasive pneumococcal disease. What about children? We will see the same result, about 2. You are 2 times the risk to have pneumococcal-related hospitalization or asthma-like symptoms if you have asthma. What about other bacteria? What about gram-negative like pertussis? You will find the same. If you have asthma, especially if you are a child in this particular bacteria, you have 2 times the risk to have pertussis infection. Moving on to the viral infection like the corona. So in 2009, we have the big swine flu H1N1 infection, and in this study, they are trying to link the infection rate in children with asthma. And you can see that this study group, where 95% with asthma, 66 child with no asthma as a control, you have a higher risk of 73% to have allergen-specific IgE. But let's move on and see. Look at this. Over time, and what they did in this study, I remember now, over 3 months, they took samples, weekly samples from these patients, and they see how frequent they acquire infections. You can see rhinovirus, adenovirus, others, more or less you have similar or even more acquiring of these viruses if you didn't have asthma. While if you have asthma, you have a significant risk to acquire H1N1. That's mean, and that's translated to, if you have asthma, your odds ratio to get infected with H1N1 swine flu is 2 times the risk. Very similar to the bacterial to the bacterial pneumococcal and pertussis we saw before. This is just not only to say if you get infected. Now we want to see if you have asthma, you have not only a high risk to get infected, you have a high risk to get admitted, to get hospitalized. And again, if you can see this this H1N1 study found the comorbidities, the underlying medical condition, the comorbidities with patients, you see number 1 was asthma. So asthma was the highest risk factor for you to get H1N1 in the United States in 2009 with H1N1 influenza virus. Not only to get admitted, also to get to the ICU, or even, unfortunately, if the case fatality rate is higher. So the odds ratio get much higher, up to 2 times the risk if you get H1N1 and you have asthma. So is that the case with a milder viruses like rhinovirus? And in this patients, they brought 76 asthmatic patients, 76 healthy participants. And what they did, actually, they inoculate those candidates with rhinovirus to see what would happen to them over time. And what they found is over time, having asthma didn't increase the risk of getting infected. These 2 arms had the same risk of starting symptoms and starting to get symptoms. Also, they don't have as different in clinical scores if they have from the upper respiratory tract. However, when they scored for their lower respiratory tract symptoms, you'll find a significant increase in the symptoms. And you can see none of the patient on healthy participant had any lower respiratory tract symptoms or infection, while you have a higher risk if you have asthma. This is to show you the clinical score over time from the day post inoculation, and you can see here that this is not only associated. Asthma is not only associated with higher risk to have symptoms. It's also is correlated to your clinical severity and how good is asthma control. If you have a higher SQ, higher objective measurement of your asthma, you have a higher risk to have daily lower respiratory symptoms. If you have a badly controlled asthma or uncontrolled asthma, the same thing you can see, uncontrolled, partially controlled, uncontrolled asthma. Same thing you can see it here between upper and lower respiratory tract symptoms. So far, we are seeing a very good, let's say, association. Let's say not a correlation or causality, that asthma is a very inflammatory disease. It's the egg, it's the chicken, that having asthma put you at high risk of infection, or infection give you a high risk to have asthma, or it's one of the causality, one of the things that give you asthma. But we can see a clear association if you have asthma with higher pneumococcal disease, pertussis infection, H1N1, rhinovirus. Not only that, you have higher risk to be hospitalized. You have higher risk to get ICU admission. You have a higher risk to die. And as on top of that, your asthma control is highly linked. So if your asthma is if the patient asthma is well controlled, they have less risk to get admitted, to have symptoms, to have low respiratory symptoms, and even admission. So people trying to see why is that the case, and they are saying maybe because our immune system is already altered, and that's why we have asthma. In this study, what they were trying to see, they want to see what will happen to the bronchial alveolar lavage cells in asthmatic patients when they get rhinovirus, and they control that with control patients, healthy patients, normal, they have no asthma. And what you can see, interferon alpha and beta, you can see in normal, they have a robust, very clear reaction after 8 hours. But that reaction in asthmatic patient is blunted, and it is less responsive than normal patient. And in 24 hours, this inflammation, it's clearly getting higher. And again, you have a delay, you have a blunted response to interferon. So is it the link? Is it the cause? Is it why those patients have more symptoms, more risk to have more asthma and more hospitalization? It's yet to be get a bit more established data about that. So now, what about corona and asthma? And before I go there, if someone at the start of this pandemic in January or February starting to talk the link between asthma and corona, what will happen if we get corona? I mean, it doesn't. It makes sense that you are basing that because corona is a brand new disease, or sorry, COVID-19 is a brand new disease. But you would base that on the previous experiences with other bacteria and viruses. That is why you will see from the narration from WHO and other health authorities, everyone saying, if you have asthma, please stay away. You are one of the big risk factor that is linked with bad outcome. I think at that time there was a lot of, let's say, analysis based on the other bacteria, other viruses. But let's dive in and see what is there any a bit more data between corona and asthma. Corona is a big family of viruses. There are 7 strains of coronavirus that can infect human. 4 give you very mild disease, and 3 give you very severe disease. That is why the least mild one, nobody, maybe most of us just heard of them during this pandemic, but everyone's heard about MERS, SARS, and the COVID, because they are much more robust, much more severe, and they give you a bit much more symptoms and hospitalization and fatality. That is why, in very understandable mild diseases, they behave like rhinovirus. They have been established as causes of asthma triggers and asthma exacerbations. What about these more severe ones? This is from SARS, and in these patients, again, it gives you the same idea that it's a bit more an adult disease rather than a children disease, as we see now with COVID-19. There was a lot of debate about it. Is it because it affects the children differently? Or some people will say because when it started, school had been shut, children were quarantined at home. So it's very difficult to tease out if it is just that the children deal with this virus differently, or they're a bit less, they are at less risk to have the disease. And at that time, and the author of that, they said it clearly. It appears that SARS does not induce bronchial hyperreactivity and eosinophilic inflammation in children. to an extent to induce asthma attacks in children. They think it's not like the other corona or milder corona or rhinovirus or other viruses like flu, and it behaves a bit differently. And they published, this is from Singapore, and they have the same results as seen in Hong Kong and nearby Hong Kong. MERS, again, no clear correlation between MERS and asthma. What about COVID? COVID started in China, so most of the studies that you will see over and over time now is coming from China. This is to see these about 550 patients who had COVID-19, and they wanted to see what are the risk factors for the severity and mortality. And all of these were adults, by the way. Half of them severe and half of them were non-severe patients. But look at that. Look at this comorbidities. Only 5 out of 548, 0.9, about 1% of this patient had asthma. And asthma prevalence in China was about 6 to 6.3%. So you will just look at these numbers and you say, it seems to be asthma is not a good or a strong risk factor to have COVID-19, or at least to have severe COVID-19 enough for you to go to the hospital or CC clinic to be screened. Remember here, the numerator and denominator of the prevalence of COVID is based mainly on the symptoms and how the testing is done and what are the testing criteria. Some will talk about the overlap between asthma and chronic obstructive or COPD. Again, I mean, the total is about 4%. And if you include those as a risk factor, again, it's less than the reported asthma prevalence in China, about 6%. This is just to show another larger study putting the comorbidities. Again, asthma is not mentioned even as a comorbidity. This is one of the largest study published from China, and it's by the CDC, the Chinese CDC, and it's about 45,000 patients, and most of those were adults. And look at this, chronic respiratory diseases were only found in 2.4%. And remember, this 2.4% may include asthma and other chronic respiratory disease, as most of those were older and may have COPD rather than asthma. The only thing that, although they were less risk, they have a bit higher risk to have a problem and to die. It just, again, there is not a strong correlation between in general chronic respiratory disease and asthma specifically with COVID. This is a different study. This study was done mainly to talk about the rate of false positive and false negative, mainly false negative testing, and they were asking for repeated testing of PCR to get to the 100% positive or positivity. But on the same study, they published this, the risk factor, the associated risk factor. And look at this, hypertension, diabetes, drug, whatever, go down. Asthma, again, was one of the least associated risk factor to be tested positive for COVID or SARS-CoV-2. In the United States, someone trying to see, we know asthma is a big umbrella. You have a lot of phenotype of asthma. You have different expressions of, you have neutrophilic, you have eosinophilic, you have preschool, you have school children, you have adult asthma, you have occupational asthma. Asthma is a big disease with different phenotypes. So someone was trying to see, and they took a subset of patients who has a bit higher risk do you hear me?
Yes.
So to have a higher, just to tease out who's at higher risk to have severe asthma. And what they found, if you have higher expression of ACE2 and TMPRSS2, which are gene expressions in sputum cells. So they will ask the patients to spit these sputums and they will analyze their gene expressions. And what they found, if you have higher expression, you have a poor outcome. And what was very interesting that they found that using inhaled corticosteroid, it may have a possible protective mechanism as the expression of these two genes were less. Trying to find anything from Italy or Spain or rest of Europe or United States and the risk between asthma and COVID, not much of data. If you Google asthma and COVID or asthma and corona, asthma and COVID-19, you'll find less than 50 publications. Half of them are review or opinion, and the rest we're talking about other than asthma. Not a lot of people trying to tease out or associating these two together. This is the distribution of age in Italy, and again, this is where we see it all over the world. It was about 1.7 in China, less than 2 or 3% in Italy. In general, children are less affected by this disease. But this just led me to talk about what happened over the last few days, where the new cases in Saudi Arabia are reported, and what the striking number is the 11% was mentioned 2 to 3 days ago from all the new cases were from children. So I think we may have a different demographic, and I think we have just to keep our eye on the evolving of the disease. I'll conclude by saying COVID-19 rate of infection is low in children. Asthma so far is not a clear risk for factor. However, as I mentioned, demographic of Saudi Arabia can be different. We have a higher, younger generation than Italy and China. Full data and details are yet to be published, especially from Europe and North America. Cautious interpretation should be practiced, especially about the numerator, denominator, test criteria, mortality, and a report of comorbidity. Asthma should be treated as per the latest practice notes published by GINA and soon by the SPPA until further knowledge and a bit more concrete data get published. Thank you very much, and I'm happy to have any questions.
Thank you, Turki. I will keep the question at the end. So now, it's a pleasure to introduce Dr. Abdullah Alshamrani. Dr. Abdullah is the director of the Fellowship Pediatric Pulmonology. Dr. Abdullah Alshamrani, he's active in research, active in a lot of activities. I will not talk about it, Abdullah, but Abdullah, mashallah, is a very good teacher. He will talk about the Saudi Pediatric Pulmonology recommendations for the asthma and COVID-19. Dr. Abdullah, please.
السلام عليكم ورحمة الله وبركاته. جزاك الله خير دكتور صالح. Is the voice clear?
So far, yes.
جزاك الله خير. شكرا لك. شكرا للزميل الآخر الحبيب تركي الأحمدي. نسأل الله العلي العظيم المغفرة للدكتورة مها. شكرا للأخ فيصل والأخ عادل الحربي لتنسيق هذا العمل. نسأل الله العلي العظيم أن يجعل هذا العمل خالصا لوجهه الكريم. نشكر الحضور، وحقيقة مسرور جدا من هذا العدد وأيضا من نوعية الحضور. فهناك ما شاء الله very good number of pulmonologists, respected fellows، وبعض الزملاء الآخرين من حتى من خارج البلد، بعض الأصدقاء من الجزائر حياهم الله. حديثي اليوم عن الأزمة in the era of COVID. الحديث very easy. I will divide it in 3 parts. The first part is the introduction, which is talking about the COVID. And majority of the COVID covered very well by Brother Dr. Turki Alahmadi. And the second part is important of asthma in the country. And the third part is the main message, which is the recommendation from the Saudi Pediatric Pulmonary Association for the patient with asthma in the era of COVID. نسأل الله العلي العظيم أن يرفع الغمة عن الأمة وأن يحفظ أطفالنا وأطفال العالم من هذا المرض ومن الأزمة أيضا. طبعا قبل أن نبدأ الصورة الجميلة هذه، طبعا منطقة البشائر هي تصاحبني في كل المحاضرات. أول محاضرة لي طبعا هي من البشائر منطقة جميلة، هي قريتي في المنطقة الجنوبية وإليها أنتسب ولها الحب كله. طيب نبدأ بانترودكشن. شكرا لتركي. تركي تحدث عن الكورونا، فمن التكرار يعلم الشطار. فالكورونا it's large family. I will not repeat. The 4 main types are mild, but the 3 severe type, which is already discussed and addressed by Dr. Turki, make it very easy for me. The SARS, okay, and this is the percentage of the mortality. I would say in pediatric 0, and the high mortality or the mortality in the adult reaching an average 15%, while the MERS-CoV, which was initially addressed here in the kingdom, 2012, the mortality in children is 6%, while the mortality in the adult ranging between 20 to 40%. طيب, how about the COVID? The COVID, as you know, started, I'm sure that everyone is fed up from the COVID, infected now more than 4.5 million. In Saudi Arabia, the first case was in March. There is a lot of activities trying to control the infection. The mortality here in the kingdom is much better than the worldwide for different reasons. We will try to discuss it later on. You know that this is the daily consensus about the COVID international wise. USA is still leading. I see the Russia is taking the 3rd place. Italy is going down, and there is a lot of change. The most important is Saudi Arabia. Saudi Arabia is still, unfortunately, increasing from the position of 36 initially to now reaching a position of 16. Still, the numbers of the cases increasing day by day, unfortunately, for different reasons. But why the subject is important? Because Corona, as you see now, is becoming really a serious issue, and it's now, you see this slide, become the 5th killing disease international wise. Okay, so now here, this slide, I would say, important in Saudi Arabia. As you see the upper part of the slide, that the number of Corona in the kingdom is increasing, and potentially maybe today is the maximum number that been reached since being discovered from the early of March. But the good thing about the country that the mortality rate is very low, an average 0.6, for different reasons, because of a lot of activities here from the Ministry of Health and supported by the government of the Saudi Arabia. جزاهم الله خيرا. ولكن أيضا التركيبة العمرية للبلد. Majority of the population are pediatric or young age group. That's why you see the mortality is different or much less than the international numbers, which is, for example, the worst in Italy. But there is a lot of change nowadays from the I would say the developed countries like UK, the France, the Netherlands, and the so those countries with a lot of elderly people, and we are expecting more mortality there. So now this is the first part. The second part is why this is important for asthma, because asthma is really very common here in the kingdom. On average, as mentioned by Dr. Saleh, is exceeding 20%, okay? For example, the maximum, the number being reported from Hafuf, 33.5, and potentially lowest, I would say from Abha around 7%. And further think that the 2/3, according to Prof. Al-Jahdali from National Guard, even it's an adult, it's 2/3 uncontrolled. I would say one of our study with Dr. Al-Sahan in King Fahd Medical City, that 50% even in tertiary center in Riyadh is still, pediatric patient is still uncontrolled. Majority of asthma international wide are still uncontrolled. Now, why it's important to discuss the asthma? Because there is similarity between the asthma exacerbation, which is increasing cough and shortness of breath and wheeze, and could be similar to COVID. Okay, COVID, what is the presentation of COVID? I will try to summarize it in the next few slides. Further, due to the curfew and the quarantine from the country, now there is a lot of stress, a lot of anxiety, a lot of fear, potential depression for a lot of patients, and even if you have heard about suicidal attempt and even suicidal deaths due to the COVID international wise. And now, how about the prevalence of smoke? The prevalence of smoke in the country is really very high, and we are worried that the parent could precipitate an asthma exacerbation due to the excessive smoke exposure. Now, since there is no medication being, I would say, approved so far, you see in the media there is many myths talking about the COVID. You start to see certain bahur, certain new medications, certain herbs, okay, and this is just trying to control such kid from the COVID scenario. Now, is the asthma patient is a target for COVID? I think it was tackled very nicely by Dr. Turki, and I'm reassuring you again. Okay, it is not. I would say strongly, as you see, this is 0.9. I would say, for example, in the China, the risk of COVID, which is much below the prevalence of the asthma there. So we know that this is majority of the data comes from the adult. The main risk factor is cardiovascular, and these are really an adult literature, then diabetic, then chronic respiratory, then cancer, and I would say, where is the asthma? So I would say it is a good news for you that asthma is not risk factor of COVID. And asthma in pediatric, usually majority is asymptomatic or have mild symptom. Mortality is almost reaching 0. So what is the objective now from the Saudi Pediatric Pulmonary Association for this COVID and asthma? So we would like to help physicians how to treat asthmatic patients during this pandemic disease. So the first questions, I would say 4 or 5 questions, then I will end my talk. Do the children have an asthma, or do children with asthma have higher risk to be infected with COVID? The answer is no. And you have seen this number from Dr. Turki. Again, different numbers or different study from the China, okay, saying that asthma is not a risk for COVID. During the COVID-19, so what are the potential problems, okay? So as again, I like the first slide by Dr. Turki, because asthma is a chronic condition, need, I would say, regular medication for certain time, and you need to ask yourself why your patient is uncontrolled, and only there is 5 questions need to be answered, okay? And there is certain protocol, as Saleh mentioned, okay? whether to follow the GINA or to follow the SINA. There is many other guidelines, but these are the two popular guidelines. So asthma is a chronic condition, chronic inflammatory condition. Okay, it should be controlled. It can be reached, but if patient is not controlled, you need to ask what is the dose, what is the compliance, what is the technique, is there any risk factor or comorbidity, or are you dealing with a different disease? So in here, there is some concern that you will be having difficulty in reaching the healthcare. There is potential shortage of medication. There is a potential up and down in the medication. Okay, and all the time you need to review the technique and avoid the risk factor, especially the smoke, as I mentioned. And you need your patient to be well controlled. So in here now, you need to have what's called written action plan, and action plan and literature is being recommended, especially during the pandemic. There is a good data that this action plan can help patient to control the symptom, can prevent the, I would say, exacerbation, and can even avoid the systemic steroid. There was some important question from Dr. Mohammed Zahrani, who's newly graduated, excellent, super excellent pulmonologist, about the systemic steroid in asthma. We will tackle that shortly, inshallah. What are the difference between the common cold and asthma and COVID? And this slide comes from Dr. Saleh Alharbi. Okay, we know that the viral illness is the main trigger for asthma. There is difficult to differentiate between these upper respiratory and the COVID. Okay, and there is, if you would like to discuss, is it flu? Is it common cold? So flu and COVID, they could be similar. They have high-grade fever and they have GI manifestation, while the common cold, for example, they have less diarrhea and less GI symptom and even milder disease. So in literatures, okay, in different research with some of my colleagues, the three main presentation of COVID in pediatric. In pediatric, number one and most important symptom is fever. Number two, second most important is cough. Number three, there is a debate. It could be fatigue, myalgia, okay, chest pain, and headache, and name it. The others, I would say, different according to different study, different percentage. Okay, so you will see shortly. This is the slide that I shared from beloved Dr. Saleh Alharbi. Okay, the corona, I would say, most importantly, keep in your mind the fever and the cough. And in here, maybe, I don't know, sometime in literature, they say myalgia or fatigue or a headache. Okay, so these fever and cough. Like, how about shortness of breath? Sometime literature could be reaching 50%. Okay, and so I would say keep in your mind now the fever, cough, myalgia, and the others. Okay, so how about, for example, the flu, as you see in here? Okay, there is, for example, there is no fever, or some fever is. Sorry, the flu. There is a potentially the flu. The influenza is clear. Difficult to differentiate from the COVID, because usually the patient is sick, high-grade fever with GI manifestation. The cold is less. Okay, so there is potentially, I would say, difficult to differentiate, but I would say summary, influenza or flu, it could be similar to COVID, while the common cold is different or more milder disease. Now, these are the summaries for the big study that's been tackled the COVID in here, just to confirm to you that the fever, for example, ranging between 36, 41, 36, 88, 98, and sometimes 73, while the second highest presentation is cough, 48, 17, 67, 76. So these are the percentage of number, and look up according to the number from different parts of the world. the myalgia, number 3, and potential tachypnea, number 4. But if you see the GI symptom, the rhinorrhea, the vomiting, and etc. So these are the, to summarize it, COVID, keep in your mind, fever, cough, and fatigue or myalgia. Shall we continue using inhaled steroid? I would say shortly, yes. Inhaled steroid is the main therapy. There is a concern now about systemic steroid, and systemic steroid being addressed, I would say, from the previous experience from the SARS. So in here, there is a debate, Dr. Muhammad and the others. Okay, so we don't have much experience because in pediatric, majority of the patients are mild. If the patient is really ARDS, okay, it could be a potential, but usually there is some debate about the outcome of the systemic steroid in the COVID patient. Anyway, the systemic steroid, okay, for simple asthma, does it increase the COVID? Usually not, okay, because usually systemic steroid limited for exacerbation, and we'll talk about this maybe in the next slide. So in here, maybe this slide talking about inhaled steroid, we should not stop inhaled steroid because it not increase the risk of the COVID, even though the patient, as you know, asthma are commonly associated with allergic nose. Even if you need the Nasonex or Rhinocort nasal steroid for allergic nose, you need to continue. So in general, the message for inhaled steroid are safe and is not increasing the risk of the asthmatic patient to get COVID. So this is, shall you continue inhaled steroid? The answer is yes. How about the oral or systemic steroid? Systemic steroid, I would say in here, should be limited for exacerbation, and we usually in pediatric use it in 3 to 5 days. Try to use lower dose, 0.5 to 1 milligram per kilo per day, and usually before we are using 1 milligram per kilo per day, 2 milligram per kilo per day. Anyway, for us, we are not seeing much. If patient is really requiring frequent oral steroid, for example, more than 3 times a year, you need to discuss why. And why, you need to answer the 5 questions. Is it a compliance problems? Is it a technique? Is it low dose? If not, it could be risk factor or comorbidity, or not. If not, could be wrong diagnosis. Can the patient continue using the nebulization? I think this is really one of the main slides. This is one of the main slides and main message today. You know that majority, especially in the private, they are using the nebulizer, whether at home or even in the main hospitals. Okay, so the group of Saudi Pediatric Pulmonary Association, we are speaking against nebulization because of risk of transmitting the infection, whether from the air itself or from the sharing the nebulizer kit. So we recommend MDIs, okay, whether at the emergency level or even at home. If it's used at home, try to limit the nebulization. I would say the kit for each patient. Each patient should have his own kit. So the recommendation, please stop using the nebulization at hospital and even at home, unless there is no alternative. And if there is no MDI, use the kit, the nebulizer kit for each patient. Good hospital now, for example, military, I would say, so they are start using, I would say, the MDI rather than the nebulizer as main therapy for asthma, even during exacerbation. Even during the exacerbation, we are supporting the MDIs. As you see this slide, we are supporting, encouraging use of MDI rather than the nebulizer. So exception, okay, in the severe asthma exacerbation, when patient is failed the initial first or second line therapy of the MDI, or the patient is uncooperative, okay, with decreased level of consciousnesses or very, very young age group, okay, then use the nebulizer plus the standard measure, which is the personal protective equipment, gloves and gown and etc. Okay, so now the main message from the group, Saudi Pediatric Pulmonary Association group, we are supporting a whole group using the MDI rather than the nebulizer. Now, what is the dose? What is the exact? So there is a lot of debate, okay, whether, but this is what we recommend. Below 20 kilo, I would say 4 puffs, okay, which is equal to 2.5 milligram nebulizer, while the kids more than 20, okay, it's, for example, could reach 10 puffs, okay, which is equal to the adult dose, 5 milligram of Ventolin or salbutamol. I know there is a debate in this, and I would like even Saleh or Turki to comment about, and I'm expecting some question from audience, because I do respect majority of them. Really, they are pulmonologists and acting pulmonologists and very respected pediatricians. So this is an area of debate between pediatrician and emergency physician and pulmonologist, but this is what is the message from the pediatric pulmonary group. So what about the follow-up nowadays? You know, there is limited access, okay? So we started now creating the virtual clinics, phone calls, and there is, we would like to, as Turki mentioned, chronic problems. So we need continuity of care. Asthma need to be treated 3 months, then after 3 months need to be evaluated and step down and step up according to the condition. And be sure that the medication reach the family despite the Hajar. What about the pulmonary function test? We would like to stop any spirometry or minimize it as much as you can to avoid transmission of the disease. And the same scenario for the extreme cases for those sick and going to the ICU, for example, the bronchoscopy and lavage, which is not the area in here. There is, I would say, could be a potential question for the fellows. Okay, there is certain precaution for, which is not beyond the scope of this lecture. Okay, when to do the lavage and what are the precaution for lavage patient if needed. Now, this is the last. The draft already sent to the Journal of International and Pediatric and Adolescent. Okay, a few days ago, and hopefully it will be published soon. Bi-idhni ta'ala, and these are the group. Okay, so the take-home message today. We need to follow the instruction of Ministry of Health. So just keep basic social distance, frequent hand washing, keeping one hand away from one's face. Then be optimistic. Children are not at high risk. Again, I'm repeating this. Children are not at high risk for COVID. Presentation sometimes could be similar. COVID could potentiate the asthma. I have seen today in the emergency a patient with COVID and he has an asthma today in military at 2 o'clock. So I think it is important for the action plan to be issued to the asthmatic patient. There is no concern of inhaled steroid in asthmatic patient. We are supporting as a group using the MDI rather than the nebulizer. Okay, you should avoid nebulizer, especially at the emergency level, and be ensured that your patient has a regular follow-up, especially through the phone call or virtual clinic. And أسأل الله العلي العظيم أن يجعل هذه الليالي مباركة لكم وجزاكم الله خير. ونرجع للمودريتور دكتور صالح الحربي ونشكر الجميع ونسأل الله التوفيق. شكرا لكم وجزيتم الفردوس.
شكرا دكتور عبد الله، الله يعطيك العافيه. دكتور تركي الله يعطيكم العافيه. دحين حنستقبل الاسئله. يمكن اول سؤال كان مكتوب من الدكتور محمد الزهراني، ما ادري عبد الله انت قلته بسرعه كده بس، يعني does the systemic steroid in asthma increase the severity of the COVID-19? Can you highlight it more?
اعتقد ذكر الدكتور عبد الله الاجابه، بس اعتقد التفصيل فيها انه if you think about it, usually the natural time or time of the disease and the progression of the disease in an asthma and asthma exacerbation is a little bit different than the COVID. COVID usually takes a bit of time. Asthma exacerbation usually it's from the onset of the viral infection to the start of the symptoms is a bit faster. The doses mentioned is hugely different. It's a smaller dose. In the beginning of the pandemic, there was a lot of debate about using steroids, so people are shying off, especially and even with asthma patients. But there was a recent case series from the United States about 4 middle-aged, or not middle-aged actually, young adults with asthma. And what they were talking about was they found that all of those has a bit of asthma as well as their disease. So they have a bit wheezing, they have a lot of something like an overlap between asthma and COVID. That all, in a short way to answer it, if it is clear asthma exacerbation, the child looks fine, well, as none of the risk factors that make you think about COVID, like contact with a COVID patient, skin rash, red eye, GI symptoms, nausea, all the other things that make you think this is not a typical viral induced asthma, shy off from steroid. Otherwise, if you think that the patient may need the steroid, use a smaller dose as possible, a shorter duration as possible, keep your eye on the patient, ensure follow-up, and see what will happen to your patient. May Dr. Saleh may mention that briefly about using the new GINA question mark, increasing the inhaled corticosteroids for a short time as an alternative for the oral steroid.
طيب شكرا لك تركي. يعني I'm supporting 100% what did you say, but message to the audience. Okay, if you have patient with asthma and systemic steroid, okay, so this is very unusual. Okay, so why? Again, back to the basic. Check the compliance, the dose, the technique, the risk factor, the comorbidity, or could be a wrong diagnosis. I would say very unusual that your patient required the systemic steroid. So, Mohammed, I would say for me strongly that and the others, the systemic steroid, yes, it is a treatment only for the exacerbation. Okay, so if your patient has exacerbation, you need to ask your patient, yourself the 5 main questions. So again, be simple. Be, I would say, clinician, okay, systemic steroid, we know that it is a treatment for exacerbation, but it's not in general for the treatment as prophylaxis or regular therapy for the asthmatic patient. Saleh?
مستني بس اشوف الاسئله في اسئله ثانيه. طيب now in the oral we have to use MDI, but what if the patient need BiPAP mechanical ventilation؟ هو بس يعني انا افضل انه ما نجاوب على السؤال لسبب انه بكره في الليرنينج ويبينار non-invasive ventilation and high flow nasal cannula in the COVID-19 patients. If you want more clarification, إذا عبد الله عنده بس short answer، لكن tomorrow في session موجود بكره tomorrow then by the good expert RTs. They will talk about the non-invasive ventilation and high flow nasal cannula, inshallah.
And I support to the group to join the lecture. It will be really very beneficial, and even myself, I will learn from it.
طيب السؤال اللي بعده regarding the step down of asthma treatment, do you prefer to delay it until the season out? لا, depend. Is it seasonal asthma? Is it a chronic asthma? Is it eosinophilic type? على حسب التايب، حسب السيمتومز، الكومبلاينس، و a lot of things يعني. But if the kind of child symptomatic in the season, yes, we do. But if not, I don't think so. كمان لازم نشوف السايد effect. If there is any side effect for the medication. There can't be concern from the family about the medication. A lot of factors.
I think the other way also to look at it is your ultimate goal is to use the least amount of medication. And I think if you have a patient that you are very relaxed to stop the medication, do that with at least having the patient has the enough medication if you need to resume it. But if you are questioning, you want to try, don't. Keep the patient on a medication. So just ابني على اليقين أكثر في هذه الأيام لأنه it's very difficult to assist the patient 100% without objective measures sometimes.
طيب في سؤال عبد الله الشمراني، هل ممكن استخدام البخار في البيت بدل البخاخ حيث ان الاهل يهتمون بالنظافه؟
والله شوف يعني احنا as pulmonologists for many years we are supporting the MDIs. Okay, I have 4 kids. All of them have asthma at one time. Okay, I never had a nebulizer at home. Okay, so I'm supporting the MDIs by all means. Okay, for many years, I would say for 20 years now, in almost 18 years, I would say in pediatric pulmonary, I'm supporting the MDI. Nebulizer, I know some of the family, they like the nebulizer. Okay, so if there is no way, okay, if the MDI is not working, okay, sometimes the family, they believe that nebulizer is the only option. So I would say nebulizer is second option for asthmatic patient. Now, majority of the family are large. Okay, so you might see 2 families or 2 at home, and now the child has, for example, fever, nose, and etc. So I would recommend, okay, to machine 1, okay, but the tube and the saline and the mask mainly, okay, should be different. Okay, should be different for each one. So keep it as an alternative if failed, because if you lift the child from the MDI is not available and you didn't give the permission for the nebulizer, they will go for the bad scenario. They will go for the cough syrup and they will go for the herbs and the others. So keep the nebulizer as alternative, okay, with certain precaution.
طيب خلينا نشوف إذا في سؤال كمان.
There was, I think,
احنا باقي لنا 3 minutes على فكرة يعني. Okay.
Someone asked about the BiBAB. I think we would like to keep it for the lecture tomorrow. And I think the Dr. Abir mentioned step down the asthma treatment. Do you prefer delay it till the season? Very good. But just from my side, just one talk. These nowadays, usually in asthma in the country, it is seasonal. Okay, majority of the asthma start with when the kids back to the school September, getting worse a little bit in the October, and now majority of the centers or tertiary center in the kingdom, they will start the prophylaxis, for example, the influenza vaccine or the Bevacizumab for the younger age group, starting from November. Okay, so November, December, then January, February are the main bulk for the asthmatic patient. The season will start fading March, April. Okay, so nowadays we are now in May. We know that there is a era of the COVID. So usually from May till September, majority of the patients, they are doing well, and majority of my patients I advise to stop. Okay, when to stop? I would say if minimum, we prefer 3 months, majority of the guidelines. But if it's difficult to the family, especially in the summertime, I give just some time personal experience, which is half recommendation. 6 weeks asymptomatic, whether no night cough, no daytime cough, or no use of Ventolin for any activities, and the child is perfect. So during the summertime, I would say maybe colleagues, they will not agree with me, but I just minimize as much as I minimize the burden of the medication for the kids, because I need the people now to give the medication early of the season, like for example, November. So I fight with the medication during the peak of the season, for example, November, December, January, February. Then I would give some relaxation during the summertime.
I think there's no more question. That's at the end. I would like to thank everybody, Dr. Saleh Alharbi for the مبادرة Dr. Maha Dabbagh, Ustad Faisal, arranging the session and webinars, Dr. Abdullah Alshamrani, Dr. Turki Alahmadi, and I will just remind you about tomorrow's session that non-invasive ventilation and high flow nasal cannula by Khalid Al-Awam and Saad Al-Rabia. So please don't forget to log in tomorrow, inshallah, for the session. Thank you, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام وشكرا للجميع.
جزاكم الله خير، شكرا للجميع ونسأل الله التوفيق ونسأل الله أن يرحم الدكتور.